Okay, thank you. Next speaker is going to be Thanainit Chotanaphuti. Hi. Talking about change of femoral offset. Are there any difference between the elderly and the young patients? Please.
Good morning. Thank you, Mr. Chairman. So I would like to share our experience about subsident. That's what the surgeon concerned when they do the cementless femoral stem. So usually it's more again popular to use the cementless stem, and they still have some problem, the loosening. So mostly the concern about the subsident. Mostly the proximal femoral morphology is the dorsal is not recommended because they're going to have the easy for the subsident. When it's subsident, they're going to have a joint instability and the limb length discrepancy. Mostly the majority of the stem with subsident in the first 2 or 3 months after surgery. And if the subsident is 3 mm, it would be the clinical significant. We use the hydroxyapatite coated taper stem for our study. And we're looking for what is the factor that related to the subsident of the stem, age, sex, dorsal, or the canal field ratio. We include 234 patients from 2009 to 2015. The average age of the patient is 63, a little bit more in female. Diagnosis is osteoarthritis, osteonecrosis, small, and a hip fracture. The average follow-up is 4 years and minimal follow-up is 2 years. First, we're going to calibrate the magnification earlier, and then we measure the limb length, the subsident, and canal field ratio. What is the result of the first? We classify the dot type A, B, and C. Most of our patient is dot type B. If you're looking for the age of the patient, in the increase from the dot type A is the youngest average age. B is a little bit older, and C is the oldest. And the sex for the dot type A, the young patient is more male patient. But for the dot type C, they have more age, and the proportion is the female. And you're looking for the diagnosis. The osteonecrosis is the young patient, dot type A, and male. And for the dot type C, it's elderly patient, and mostly female, and hip fracture. So we consider the post-operative parameter. When we use the stem size, we increase from the dot type A, a little bit bigger in B, and bigger in C. But we consider the canal field ratio is not different between dot type A, B, and C because we use the stem is bigger. And we use the multivariate ligation analysis to see the subsident. We found that the dot type C have significant subsident when compared to the dot type A and B. But the subsident is less than millimeter when compared to dot A, B, and C. And the age, they have a negative correlation. When the patient get older, they have a less of the subsident of the stem. When we consider the most that we scale is more subsident, 3 millimeter. So we analyze the patient have 3 millimeter subsident. We found 54 cases have the 3 millimeter subsident. So we use a multi-ligation analysis when just with the canal field ratio. We found that the canal field ratio did not associate with the subsident and no significant. Even you can do the more proximal fit. You have a fit at the lesser torque or distal 2 centimeter from the lesser torque or 7 centimeter from the lesser torque. And we consider the logistic ligation for analyze what is the factor of the 3 millimeter subsident. We not found any related with age, sex, or dot type. We found that younger or older, they're going to have the same chance of subsident. Female or male, they have the good proportion to a subsident. Even the dot A, B, or C is the same. And when we use the logistic ligation, consider about how fit of the stem to the canal. If we not found any difference for the canal field ratio. So for our discussion, when we consider only the subsident, the proximal femoral morphology has a factor that related to the subsident. Dorsey have the significant amount of subsident, significantly, but just only 0.7 millimeter, at they have the show in the many literature. However, when we did not found any criteria for the when we consider 3 millimeter subsident, because we look at the detail when the patient have the door type C, the surgeon they push more bigger stem and they have a good canal field ratio also. So for the proximal femoral morphology, that's significant associated with the subsident of the HA coated taper stem. But in 3 millimeter subsident can occur in all type of the door, and is not related to the age, sex, or canal field ratio. And mostly the subsident occur in just first 3 months, and then it stop and stable position. For our study 234, we don't have any case for the revision of the femoral stem. We also found that they have a net offset and a little bit change. So until now, and for the minimum 2 years, we have close to 1,000 cases. We use this type of the stem. We use it for primary hip and hemiarthroplasty. We have 3 cases to reoperate. The first 10 cases, we have 1 case of the early subsident 1 centimeter, and we revise it. And now we not believe in the cancellous infection for the cancer, for the cementless stem. We put this very big stem as much as possible. And we have 1 case of the revision because of the 8 years ago we used the ceramic on metal. We have 2 cases of the pseudotumor, and 1 case we have to revise because of the osteolysis, and the other case is a PJI. So in conclusion, femoral offset decrease with age, and HA stem there increase a little bit offset. The subsident of the femoral stem associated with door type C. And we consider the subsident 3 millimeter, they can happen in any of door type, sex, age. And even a good field of the femoral canal, we not found any difference in canal field ratio also. Thank you for your attention.
Thank you very much, Thanainit. Questions from the floor, please.
Thank you for that excellent presentation. My question to you is, if you're going to consider using a stem like a Thanainit type C femur, I noticed that all of your stems were not colored. There's a color option. Would you advocate using that to avoid early subsidence?
We studied 9 years ago. They don't have any color at that time, and we just do it with the colorless, and we analyze it. It's a little bit subsident, but it's all stable. We don't have any problem with the elderly hip fracture with the collarless HA coated stem. We don't have it, but it put it very large. We put it very large. For the first 2 years, we use the cancellous infection also, and then we found that it's maybe not useful if we put the largest as possible for the door type C.
Thanainit, to my understanding, you didn't find any real reason for subsidence of more than 3 millimeter. So what is, in your opinion, the main reason? Is it at the end the surgeon related? Because he chose a too small implant, or the...
we analyze the canal field ratio. It's the same. When it's with door type A, we fit it and we calculate the canal field ratio. So A, B, C, this is the same of the canal field ratio. The surgeon do it properly for the place the stem. I think it's the collar and the early ambulation, because now we allow the patient to walk quite early, and it is cementless stem and no collar, so they're gonna start subsident a little bit.
Okay.
If you scale the subsident, it's good idea to delay a little bit ambulation or use the collar.
Okay. Thank you very much.
Thank you.